Welcome to HealthWatch, presented by Novant Health. I'm your host, June Baker. Our show today features our newest Novant Health primary care physician located at our South Brunswick office, and that's Dr. Tara Craig. And next we'll meet Dr. Colston Edgerton of Novant Health General Surgery located in our Wilmington offices. And finally, we'll welcome Lindsay Karamihalis, a new physical therapist located at our brand new Novant Health Rehab Center in Charlotte. So stay tuned for today's episode of HealthWatch. Please welcome our first guest, Dr. Tara Craig, who's with Novant Health Family and Internal Medicine in South Brunswick. Welcome to our show, Tara.
Thanks for having me.
It's great to meet you.
Good to meet you.
I know you've been with us a short time. So tell me a little bit about where you went to school and where you have recently worked.
Okay. Well, I grew up in Texas, born and raised my entire life.
Really?
And then I went to college in Charlottesville, Virginia at UVA. Went back to Texas for med school, and then came back here to the beach for my residency, my medical training.
Where'd you do your residency?
It's with Tidelands. It's in Merle's Inlet.
Yes, I know where it is.
Residency program in Merle's Inlet. So not too far away.
So you're kind of a local person.
Kind of local, yeah. I mean, their areas are pretty similar for sure.
Yeah, well, that's a quick drive. I mean, you know, a lot of us go to, I have a place in North Myrtle Beach, so I'm down there a lot.
I know, and I had been commuting for a little while, so not too far away.
Yeah. So when you finished your residency, are you just recently out of residency?
Just recently out of residency, yes.
So what drew you to, I think I know the answer to this, what drew you to coastal North Carolina?
Well, the coast definitely grew on me during residency.
I bet.
And, you know, Texans never want to leave Texas, but I got married to someone who's from Charlotte, and he lives here locally. He works for Novant, so marriage drew me here to coastal North Carolina.
I kind of figured that, but I needed to ask it anyway. So it's really nice to learn about our new physicians and introduce them to the community at large. So this show does a great job of that. I wanted to ask you some general questions about women's health, including routine screenings, and there are a few. But I wanted to start with mammograms since the month of October is Breast Cancer Awareness Month, and it's right around the corner.
Yes.
So talk to me a little bit about screening mammograms and how often and when do you start getting them?
Yeah, so I think you used a good word, routine. So for the average woman, it's actually, for us providers, there are 3 different guidelines, or actually more than 3 that you can follow. But to make it really simple for patients, somewhere between the age of 40 and 50, you know, gynecologists, family doctors, American Cancer Society can all agree between those ages is when you should start. But so 40, I would open up the conversation, but we can all agree that by 50 years old, you should have had a mammogram, your very first one. And typically that's every 1 to 2 years, depending on the provider.
Oh, you can go 2 years.
You can, and I would say it's pretty provider dependent and what specialty they fall under. And then also just depends on your whole history too. There are certain things that we might want to keep an eye on you closer or let you go a little bit further without screening. So.
Yeah, I assume there are some women who are at higher risk. What might some of those conditions be that would put you at a higher risk? Are they familial? If it's your mother, your sister, things like that?
Right. I think the biggest thing for patients to kind of, there's a lot you have to remember, but just any family history of breast cancer, I would bring it up and then kind of let your provider help you decide whether it's a a distant relative or a mom or a sister, things like that. But any family history of breast cancer, if you had a male in the family that had breast cancer too.
Oh, wow.
And then ovarian cancer or other cancers, these are things you want your provider to know. But on that initial visit, we could do a good intake of your whole history. So it's good to bring things up, but these are also things we catch on our end too.
So someone with a higher risk might start their mammograms earlier.
Yes.
Is that correct?
Definitely.
Great. Well, that's really good information. What are some of the other screenings that women need to pay attention to?
Yeah, so pap smears is something that everyone's aware of, and that starts at age 21. All the way up until 65, and again, those ages, it just depends on your history. So if you're someone with an absolutely normal history your whole life, that's pretty much the age range. And you get them every 3 to 5 years, again, depending on your age. So these are things we help guide you, let you know how often you need to come back and get them. But
so there's a lot of guidelines.
There are, and they vary, and so it's good to be checking in with your primary care provider annually so that we can help you meet all these guidelines.
How about colonoscopies? How often do they recommend those for women, and when do those begin?
That's a good one to bring up because recently we've changed this, and this one is across the board. Colonoscopies are now starting at 45 years old.
That's a change.
Previously it was 50, and this is for your average person without any big risk factors, which I can touch on. But colonoscopies now start at age 45. So if you're at average risk or just routine screenings. Things that you might need a colonoscopy earlier for, and things you want to let your doctor know, is if you have a family history of colon cancer, if you have a history of Crohn's disease or inflammatory bowel disease, or any genetic inheritable things can make you need screening earlier.
Yeah. Well, let's switch gears to something that's pretty common around here, and that's high blood pressure.
Yes.
We live in the stroke belt. So why is it so common in this area, or why is high blood pressure so common these days? Is it our diet? Is it our...
It depends, but I think a lot of it does have to do with diet and exercise and the amount of salt we eat, things like that. And if high blood pressure is a problem, if it goes on for a long period of time, and it can lead to heart attack, stroke, kidney disease, even there are some studies that show cognitive impairment over time. And so again, just checking in with your doctor every year just to catch it early and to have us help promote healthy lifestyle tips for you to try to prevent yourself from falling into that category.
This is a great retirement area, and we have lots of seniors, and depending on what you term a senior, because nobody wants to say they're a senior. We all think we're still real young. I've noticed a great trend in switching from like tennis to pickleball. Do you find that in your practice? Have you heard about how common it is to play pickleball?
Yeah, I've heard that it's so common that sometimes people complain to their HOAs because it's so loud and keeping other people up at night. But
really?
Yeah. So,
oh my goodness.
I don't know if you ever heard the pickleball sound, but it's pretty loud.
Oh, does it?
Yeah.
I haven't heard that. No, I don't play pickleball, but I know a lot of people who do. And they're people that I found were not great about exercising, but they have found their niche in pickleball. So it must be, it must not be as strenuous as tennis. I don't know.
Yeah, it's less running around the court. The court's
smaller.
It's smaller.
Okay.
But I've seen people sweat, get their heart rate
yeah.
up playing. So I think it's a great start if you're interested in trying to find some form of physical activity, for sure.
So before we close, is there anything else that you would like to add?
Yeah, just want to promote everyone eating healthy, exercising, picking up pickleball. If you smoke, quit smoking. good sleep hygiene, all these things are also preventative medicine and can make your doctor's office visits very quick if we keep up with these things. So, yeah.
Well, my husband went to the doctor the other day and he had dropped 25 pounds and the doctor said, "How did you do that?" Yeah. Because I tell people all the time they need to lose weight. You're the first one who's walked in lately and you've lost 25 pounds. So
we can definitely learn from our patients. So
yeah. Well, thank you again for being here today. I look forward to having you back.
Thank you. Yeah, thanks so much for having me.
It's been my pleasure. Our next guest is Dr. Colston Edgerton with Novant Health General Surgery in New Hanover County. Dr. Edgerton, thank you so much for taking time out of your busy days to be with us.
Thank you for having me, June.
I'm really excited about this topic because I don't know a whole lot about this. It's really interesting. But before we get into that, let's talk about your background. So where did you go to medical school?
So I went to medical school at Wake Forest, and I went to undergraduate there as well.
My kids work there.
Really?
Yeah. So you went to undergrad there too?
I did.
Really?
What we call a double deek.
Yeah. Okay. So tell me about your residency and your fellowship.
So my residency was at the Medical University of South Carolina in Charleston.
Oh, MUSC.
Mm-hmm. And it was there that I first became interested in bariatric surgery. Mm-hmm. I also became interested in what we call foregut surgery, which is procedures that address conditions affecting the esophagus and the stomach, as well as advanced hernia repair techniques.
Wow. So that is really, really interesting. But if you've been in Charleston, why did you move up this way?
Well, I have always had family in the area, so my aunt and uncle and cousins were from Wilmington, and then my grandparents were in Wallace, and so we would always vacation at Topsail Island.
Wow.
So I certainly had a connection to the Wilmington area, and then I met my wife in residency, and her family lives in Wilmington as well. So it certainly kind of put it on the map for us, and following my fellowship training, which was in Boston, at Brigham and Women's Hospital, which is a teaching affiliate of Harvard Medical School, I had an opportunity to return to Charleston and was on faculty there for 2 years.
Nice.
And was very happy there, but the opportunity came up to come here for a bariatric surgery position.
Yeah. The reason I ask is Charleston is just so awesome, and if you're there, I just wonder why you would come up this way.
Well, it was really the job opportunity.
Yeah.
The more that I learned about it and the outstanding group that's here at Novant Health, I became really excited to work with the colleagues that are here, several fairly well-known physicians and surgeons in their fields, and that in combination with the family connections felt like it was an opportunity I couldn't really pass up, and so excited to be here.
Well, that's great to hear. So let's talk about bariatric surgery. So probably you better explain a little bit about what it is.
Sure.
And then who is a good candidate for that?
Sure. So to start out with who's a candidate, it's really based off of historical definitions that insurance companies have used over the past several decades, but it's based off of weight. So we use what's called the body mass index, or the BMI, and patients qualify if their BMI is greater than 40 or greater than 35 with certain qualifying medical conditions. And so those are conditions that are traditionally associated with what we call the metabolic syndrome, things such as diabetes, high blood pressure, high cholesterol, obstructive sleep apnea. So if your BMI is greater than 35 but you have some of those medical conditions, then you're considered to be a candidate for bariatric surgery. And so just to answer your question, what is bariatric surgery? Historically, we thought of it as weight loss surgery, but because it addresses a lot of the medical conditions that I discussed, it's really being referred to as metabolic surgery nowadays, because it's not just weight loss, but it's been shown to be the most effective treatment for many of those conditions.
I did not know that. I had not read that. That's interesting. Are these minimally invasive procedures, or are they?
They are. So when they were first starting, they were not minimally invasive surgeries. But over the past several decades, those techniques have been refined so that it's standard practice nowadays. So they can be performed either laparoscopically, which uses kind of the straight stick instruments where you're standing at the bedside next to the patient, or what we're doing more of today is robotic surgery, using the Da Vinci robot to perform the same surgeries that we kind of perfected and learned how to do laparoscopically.
Oh, that's good to hear, rather than all this open stuff. So I've often heard that sometimes people have to lose weight in order to qualify for bariatric surgery. Is that correct?
There are certain requirements based off of people's insurance companies and kind of what they mandate. So rarely is there a number of weight loss that people have to achieve before surgery. However, many insurance companies will require an attempt at medically supervised weight loss. So just using diet and lifestyle changes before they will approve the surgery right away. And so this can be a little bit frustrating for patients who maybe have tried a number of things over the years, that have been unsuccessful, only to be told by their insurance companies that they need to do something else. But that's where it's our responsibility as a program to kind of identify what those requirements are for patients and make sure that we kind of explain everything and lay it out to folks so that that journey from when they first become interested in surgery to when they actually can have the surgery is stress-free and kind of straightforward as possible.
Yeah, I would imagine that's stressful when you say, oh, but you have to lose weight first.
Right.
That would be very, very stressful. Are there common questions that your patients come to you with? Is there do they all ask the same questions?
Well, I think the first most important thing is patients not realizing that they're a candidate for surgery. So if you look at the data across the country, less than 1% of the patients who qualify for bariatric surgery actually receive it. And so that means that there's a large number of patients who might achieve the benefits, as I was saying, not just for weight loss, but also for curing some of their medical problems, getting them off of their diabetes medications, off of their high blood pressure medications, who don't really realize that they're candidates for surgery. I think sometimes they've seen shows on TV, that kind of fulfill a certain stigma that they might have. But the first step is educating patients and other healthcare providers that there's many more patients who stand to benefit from these types of surgeries. So that's kind of the first question that I get is, am I a candidate and how can this help me?
Wow. That is really interesting. What's the recovery time like?
So with essentially all of these procedures being done minimally invasively now, the recovery is often quite quick. So patients spend one night in the hospital. We're actually doing some of these outpatient where folks go home the same day. But for the most part, folks will come into the hospital at least for one night and then rarely need much in the way of pain medications after surgery. We want them to be on their feet, walking, going upstairs, exercising pretty soon after surgery. We just say no heavy lifting for a couple of weeks. And then probably the biggest recovery for these types of patients is just adjusting to the new diet.
Yeah, that's what I was going to ask you about that.
Yeah, so that's something that we really rely on preoperative education. We work closely with dietitians who go over what the expected transition to kind of a post-operative diet would be, and kind of getting used to smaller portion sizes. That really is the biggest transition for the first month after surgery. And then after that, it becomes fairly normal for folks to be used to that. Surgery is just one step of what is really a lifestyle change. And so educating patients with the help of our nutrition and dietitian colleagues it really empowers patients to be able to have the most benefit from the surgery that they can have. So if they're combining the anatomic changes that I perform with the surgery with better food selections and exercising and things like that, then patients are much more likely to kind of achieve the maximum amount of weight loss that they can, and also to keep that weight off for decades into the future.
So the treatment doesn't end with the surgery. There's lots of learning to eat the right foods and...
Right, and we like to make sure that patients go into surgery as well prepared as possible because we really don't want people to have to learn a lot on the back end and say, oh, well, if I had known that it was going to be adjusting a little bit, or I wish that I had known certain things before surgery. We really like to be upfront and honest with patients about how it might be smaller, more frequent meals rather than sitting down to 3 large meals every day. So I've had patients that are in the food and beverage industry or are truck
Yeah, I
drivers and
can
are on the
imagine.
road
Yeah.
for a long period of time.
McDonald's.
Yeah, and so once they understand that and get used to it, it really not only empowers them, but I think it
Sure.
makes them really excited about the opportunity to kind of engage in those lifestyle changes that without surgery, maybe they had tried in the past and were unsuccessful. But again, what I like to say is that if you combine the changes that we do with surgery with that commitment, that's where patients, really can have the most benefit and see the best outcomes.
That's a very interesting topic, and I hope that you'll come back again because there's just so much more to talk about. But thank you so much for coming
Absolutely.
today, and like I say, I hope you'll return.
Thank you. Absolutely. We'll do.
Thank you.
Thank you.
Our final guest today is Lindsay Karamahalis, and she's a physical therapist with Novant Health Rehabilitation Center in Charlotte. Welcome to our show, Lindsay. It's such a pleasure to have you.
Thank you for having me.
Good. Well, tell me a little bit about your background, where you went to school, and so our viewers will get to know you.
Sure, I'm originally from Florida. I went to University of Florida for my undergrad degree in applied physiology and kinesiology, and then I moved to High Point, North Carolina for my doctorate in physical therapy. And I graduated in April 2022, so I came out here to start my career.
Well, great. We're glad to have you. So, was there a reason why you chose this field? Had you had some interest in it prior to school? Or?
Yeah, I was actually pretty lucky growing up in that I decided I wanted to be a PT when I was in middle school. So it was kind of just something that clicked for me.
Oh.
My mom's best friend was a physical therapist.
Oh,
So I had that exposure, and then
Yeah.
I just always hung on to that idea, and then eventually, became
that's
a PT.
awesome. That's awesome. Sometimes, I know my oldest son was going to be 14 different things before he ever decided what his major was, you know. You know what I'm saying?
Yeah.
So you focus on pelvic rehabilitation, correct? So that's a new service for us here. We've not had that. So I'm really excited for you to explain to us what the goal is for pelvic rehab.
Yeah, so I would say my overall goal is to just get people functioning better. Education regarding what's going on can be really powerful. So spreading that education, taking a look at, are they having pain? Are they having weakness? Are they having mobility deficits? Is that interfering with their pelvic floor? I would say just taking a look at the person, getting to know their history and kind of what's been going on, and then addressing what I find on my physical exam too.
Well, what kind of symptoms would they exhibit?
Yeah, so I see a wide range of things, and men and women too. So that's something that a lot of people, I guess you could say, don't realize that we can see both men and women. So commonly we'll see someone if they're having urinary incontinence, frequency, urgency, and then pre and postpartum women. We'll see men after they've had a prostatectomy. So commonly they'll experience some leakage with that. So we teach them how to properly use the muscles that they haven't had to use before. And then I can also see pelvic pain, pain with intercourse, testicular pain, some gastroenterology things, so constipation, irritable bowel syndrome.
Wow.
Yeah.
I didn't realize that the pelvic floor
Oh, yeah.
affects all that stuff.
All connected.
Yeah, how about back pain? Is that?
Sure, yeah. Yeah, it's tied in. So I always do a screen. I'll always screen for back pain, hip pain, and SI joint pain, and treat those. Typically, I'll treat those first and see if I can have an impact on the pelvic floor symptoms. Since everything is related, the pelvis is kind of the whole anchor to the body.
I think I need to see you. I have that SI.
You should come.
I think I need an appointment. I'm curious, are there many misconceptions about pelvic health rehab?
Yeah, I would say one of the most common misconceptions is that, oh, like, what can they do for me? I do Kegels, and Kegels is like the $1 million word. Or
I know.
So it's so much more than that. And I'm never seeing a patient and just prescribing them Kegels. That might be something that we do and call it pelvic floor contraction for strengthening, but it's not just that. It's so much more than that. So that would be one common misconception. The other one you kind of touched on is that both men and women have pelvic floors, and they have the same muscles down there. It's just a little bit different in regards to the anatomy. So yes, men have a pelvic floor. But yeah, those are pretty much the two common misconceptions. Oh, another one I do hear a lot as well. I'm getting older, so it's I just expect it. Like, there's nothing you can do for me. It's just I'm old. And yeah, I mean, it increases in prevalence, leakage as you get older, but that doesn't mean there aren't things that we can do to help.
Right, yeah. When you're in therapy for this, is there like a set amount of time it takes, and like how many sessions do you have?
Yeah, it's a wide range. I'll give you a range though, anywhere from 4 to 10 visits.
Oh, okay.
Yeah, and it's based on history, complexity of the problem, but yeah, I mean, I've even seen someone in just 3 visits. So it just depends what they've got going on and how much we can tackle, you know. But I don't like to see someone for more than 10 visits. I don't want to draw it out. I want to give you the tools to do it at home.
That's what I was going to ask you. So I assume that after your treatments are finished, that there are exercises that have to be done for probably the rest of your life?
Yeah, it all comes into managing the symptoms. So maybe you're not doing them as much as you were at the beginning because your body is just adapting and healing. So, but I do like to have people be independent with their home program. So I want to give you the tools so that if this problem does come up again in the future, you know exactly what to do. And then if you do need me, you can always come back. But that's always one of my goals that I write is independence with home programs so that they are confident in what they need to do and can manage their symptoms well.
I know that you all just moved into your beautiful new facility in Charlotte, and I'm curious, when you're doing your exam, is it a more private area? Can you talk to me a little bit about that?
Yeah, so I have a private treatment room there, and I'm very lucky. So I've been in other clinics and it's very small and feels cramped, but it's beautiful. It's a big treatment room. So we have room to move, we have a table, and then somewhere to put your things, but it's all private.
Because I think that that might, folks might need to know that.
Oh, absolutely. And everything is done with privacy in mind. So, and also whatever someone is comfortable with, that's where we go. We don't, you know. If I guess something that comes up is, do I have to do an internal exam? And I like to say that there's so much more we can try before we go to that.
Okay.
So I don't ever push that on anybody. I will say if we've tried other things and they haven't worked, that is a really good way of getting to the problem and letting me actually assess what's going on. So it's an option, but it doesn't have to be.
Okay, because I think that would come up in people's minds. Would there be an internal exam and and the privacy issue? Because a lot of physical therapy offices, there aren't a lot of private rooms, and I think that would be a hindrance to some people. So it's great to know that privacy is really taken care of there, and that it's not always an internal exam.
Right.
So, well. That's a lot of information, and I really would like you to come back because I think there's other things we can talk about, and I'd love to get you out to meet some of our providers to talk about your new services and our new services since we haven't had this. So thank you so much for coming today. I appreciate it. You've been a delight.
Oh, thank you so much for having me.
You're welcome. Thank you once again for joining us today. If you have any questions about today's episode or maybe you're new to the area and you're looking for a new physician, please visit our website at novanthealth.org, and there you'll find that information. So I'll see you next time right here on HealthWatch.